Committee on Homeland Security will come to order. The committee is meeting today to receive testimony on the federal response to the coronavirus. Without objection, the chair is authorized to declare the committee in recess at any point. Good afternoon. Today, the committee is meeting to examine the federal government response to the novel coronavirus pandemic. As a nurse, I want to open by encouraging everyone to visit coronavirus.gov for the most up-to-date information from the Centers for Disease Control and Prevention. And take care to practice habits that'll keep us all safe. Wash your hands often with soap and water or use hand sanitizer. Don't touch your face, cover your coughs and sneezes, and avoid close contact with others if you or they are sick. We know that the spread of coronavirus has likely not yet reached its peak, and it's affecting all of our communities. I don't think there's a person in this room who isn't worried about an elderly or immunocompromised relative's health, a friend's job, or a child's school closure. Just yesterday, the first 2 cases were diagnosed in the counties that I represent in Illinois. Our jobs as members of Congress is to keep Americans safe by working with the executive branch to lead a strong federal government response, including the House-led $8.3 billion supplemental funding package that passed last week. A strong response must include each of these 3 elements. First, we must continue to support our local and state public health departments, our healthcare system, our emergency responders who are at the front lines of this outbreak. This starts with having reliable data to make decisions, like how to prepare for a surge to our health system and how much personal protective equipment is needed for health workers. It also means developing and disseminating clear, accurate risk communication to the public. America's scientific and public health expertise is unmatched throughout the world, and it must be driving our decisions. Second, we must protect people from healthcare costs associated with coronavirus. Testing and treatment must be widely available at no cost to patients, and price gouging of medical essentials and other supplies must be stopped. If we do not take these crucial steps, the epidemic will worsen because families will avoid seeking care for fear that they can't afford it, and our communities will be less safe. Third, we must soften the economic impact of this crisis on American families and small businesses. This means paid sick leave for every worker, unemployment insurance, and food assistance if needed. Given the committee's jurisdiction, today we will also examine the Department of Homeland Security's role in the coronavirus response effort. The department plays a key role in protecting workers on the front lines of this outbreak, processing travelers entering the U.S., and referring them for screening by healthcare workers as necessary. We will have questions today about the efficacy of this screening and how it's being performed at our air, land, and seaports. We also want to learn more about the department's ability to protect its own workers, whether it has adequate personal protective equipment for frontline personnel such as Customs and Border Protection officers, Border Patrol agents, and Transportation Security officers. Finally, we want to hear about what plans the department has to ensure continuity of operations at certain essential facilities in case of outbreaks there, such as ports of entry, TSA checkpoints, and immigration detention facilities. Today, we're joined by Mr. Ken Cuccinelli, who's currently serving as the senior official performing the duties of Deputy Secretary of Homeland Security to respond to these important questions. Mr. Cuccinelli is also the department's representative on the White House Coronavirus Task Force. I hope to hear from him about the work of the task force this afternoon. He's joined by Dr. Stephen Redd, a medical doctor and epidemiologist with decades of experience with the Centers for Disease Control and Prevention. It's my understanding that Dr. Redd was due to retire this month, but he's agreed to stay on to assist with the coronavirus response. We thank you, sir, for your dedication and service to our country, and thank both of our witnesses for being here with us today. I look forward to a productive dialogue with my colleagues and our witnesses today. The chair now recognizes the ranking member of the full committee, the gentleman from Alabama, Mr. Rogers, for an opening statement.
Thank you, Madam Chairman. I want to thank the witnesses for their presence and for your preparation. I know it takes a lot of time and effort to be here and prepare for it. We appreciate that. It's very helpful to this committee. As I said last week, our hearts go out to those who have lost loved ones and to those who are currently undergoing treatment. This is a global event and requires a global response. Our country has faced outbreaks of serious disease in the past. In each case, we've marshaled our collective resources and ingenuity to overcome these crises. I'm confident that'll be the case with COVID-19. Congress has worked closely with current and past administrations to prepare for outbreaks just like this. Last summer, the President signed into law the Pandemic and All Hazards Preparedness Act to enhance government authorities and authorize funding for emergency response and medical countermeasures. Since 2015, under Republican leadership, we've increased funding for infectious disease response by 70%. And just last week, we came together in a bipartisan fashion to provide over $8 billion to help keep public officials able to respond to this crisis and expedite the development of a vaccine. I hope the spirit of bipartisanship will continue as we look at ways to shore up the economy in the wake of this crisis. But I'm concerned about the petty political attacks on the administration's response, such as the majority's attack on the vice president. The Bipartisan Commission on Biodefense, as well as the panel of health experts that appeared before us last week, agreed that the vice president should be the one leading the response. The vice president is the only one with a direct line to the president and the authority to achieve a whole-of-government coordinated response to this outbreak. And unlike the Ebola czar named under the Obama administration, the vice president is in the chain of command, and he didn't lobby for the pharmaceutical industry. Last week, we heard from a panel of medical experts who all agree that the government is doing the best they can under the circumstances. Today, we have the CDC and the Department of Homeland Security here to talk about their response efforts. I'm interested in hearing how the agencies are using the supplemental funding Congress provided last week, as well as what additional authorities they need to effectively respond to this crisis. In the middle of a crisis like this, it's very important for political leaders to avoid flaming the fire of hysteria. Our job should be to support the response effort and to provide the public with accurate and timely information to keep them safe. I encourage everyone to heed the advice of our medical professionals and our chairwoman. Wash your hands, stay home when sick, visit the Center for Disease Control and Prevention's website for updated information. With that, I yield back the balance of my time.
The chair now recognizes the gentleman from Mississippi, Mr. Thompson, for an opening statement.
Thank you very much, and I appreciate the Vice Chairwoman's handling of the meeting today. I have some talking problems, so I'll be short. But let me say the witnesses we had last week said absolutely we have to have effective communication in a situation like this. People have to tell the truth. Well, I'll just say some of the things that we've heard in the past. The president called the governor of the state of Washington last week a snake. Well, that state has been the most heavily hit state during this crisis. Our president just can't call another governor a snake. And then, in the same sense, the vice president turned around and said he's one of the best people doing the job addressing it. So I think communication and how you outline this is very, very important. When this issue first came up, a lot of people said it was a Democratic hoax. It was never a hoax. We have video where people said it just should not be. So in the interest of getting and addressing this problem, taking the whole of government approach, I would encourage us to deal with the facts. But it starts at the top. If the top is calling names, people have to respond. And I think going forward, if we can agree that we will not call names, we'll address the issue. A lot of communities are concerned, from New Jersey to New York to Texas, all over. Everybody's being impacted. Most of us who came to Washington this week, there were a lot of empty plane seats on those planes coming to Washington because people don't feel comfortable in terms of flying. Some of the people on the planes have masks. And we've been told by professionals the mask really doesn't address the problem. So I would hope, Madam Chair, that with our experts here today, we'll hear the facts. And with that, I yield back.
Other members of the committee are reminded that under committee rules, opening statements may be submitted for the record. I welcome our witnesses. Mr. Ken Cuccinelli currently serves as a senior official performing the duties of the Deputy Secretary for the Department of Homeland Security. He is also the Department of Homeland Security's representative to the White House Coronavirus Task Force. Previously, he served as Acting Director of U.S. Citizenship and Immigration Services. Mr. Cuccinelli was Attorney General of Virginia from 2010 to 2014. Next, we have Dr. Stephen Redd, who is the Deputy Director for Public Health Service and Implementation Science at the Centers for Disease Control and Prevention. He previously directed CDC's Office of Health Preparedness and Response, where he was responsible for state and local readiness and emergency operations. Dr. Redd is a medical doctor and epidemiologist with 30 years of experience at CDC. Without objection, the witnesses' full statements will be inserted in the record. I now ask each witness to summarize their statement for 5 minutes, beginning with Mr. Cuccinelli.
Thank you, Vice Chairman Underwood, Chairman Thompson, Ranking Member Rogers, and distinguished members of the committee. It's my honor to appear before you today to testify about the work of the Department of Homeland Security, what we're doing to respond to the current outbreak of the coronavirus. Very proud of the work the men and women of DHS and our partners at the Department of Health and Human Services and across the government are doing. The department's top priority is the safety and security of the American people. DHS is taking action at airports and land ports of entry to support HHS in slowing the spread of the novel coronavirus, to say nothing of our maritime work. DHS continues to work very closely with our partners at CDC to route all admissible persons who've been in mainland China and Iran in the previous 14 days to one of 11 designated airports of entry where the federal government has focused public health resources. At all ports of entry, CBP officers continue to remain alert and notify CDC and other public health officials when encountering passengers exhibiting signs of overt illness, regardless of their travel history. DHS CWMD is currently supporting CDC's enhanced entry screening efforts through agreements with state, local, or private sector emergency medical services, public health, and first responder personnel at all 11 designated airports of entry for passengers who have been in China or Iran within the previous 14 days. CWMD supports the collection of passenger information for CDC to provide direct information to state and local public health officials to facilitate contact tracing efforts. CBP and the Coast Guard continue their work to recognize, detect, and assist individuals arriving through our land ports and waterways. In coordination with the CDC and U.S. Coast Guard, CBP has measures already in place at all ports of entry to identify travelers with overt signs of illness to minimize the risk to the public. U.S. Coast Guard reviews all advanced notice of arrivals 96 hours in advance of the scheduled arrival of a ship in port. The Coast Guard captain of the port communicates any concerns stemming from sick or deceased crew or passengers to their Coast Guard chain of command and the cognizant CDC quarantine station, who will coordinate with local health authorities. This process has been working smoothly across the country. At and between land ports of entry, CBP is identifying persons with recent travel to China or Iran and making appropriate referrals to CDC or the local health system. The DHS workforce is our greatest asset, and every precaution is being taken to keep our workforce safe, especially for our officers and agents on the front lines. Ensuring that these individuals and all DHS personnel remain safe and healthy is a critical, and immediately upon the onset of COVID-19 as a global concern, the department proactively took action. The DHS Management Directorate has established a Workforce Protection Command Center to ensure that protective procedures are in place for the frontline workforces who may regularly encounter potential disease carriers, and is working with all DHS components to assess their readiness. CWMD continues to work with the U.S. government interagency, state governors, state and local public health agencies, non-governmental organizations, the governments of Mexico and Canada, and private industry partners and stakeholders on medical and public health coordination and information sharing. The Cybersecurity and Infrastructure Security Agency, CISA, has been assessing the national critical functions for potential impacts to infrastructure and systems from COVID-19 and is working closely with private sector owners and operators to identify issues of concern and ensure continuity of these critical assets. FEMA is providing support to HHS as the lead federal agency in the areas of incident management, resource planning, and federal interagency coordination. Additionally, FEMA remains postured to support HHS with consequence management to anticipate any mitigation actions. The American public can be assured that DHS and its component agencies are taking decisive action to analyze the threat, minimize risk, and slow the spread of the virus by working closely with CDC health professionals and interagency partners involved in this whole of government effort. I want to thank you, Vice Chairwoman Underwood, Ranking Member Rogers, Chairman Thompson, and the members and staff of this committee for the support you've shown the department and the government's effort to respond to COVID-19. I look forward to your questions.
Thank you for your testimony. I now recognize Dr. Redd to summarize his statement for 5 minutes.
Good afternoon, Chairs Underwood and Thompson, Ranking Member Rogers, and members of the committee. Thank you for the opportunity to talk with you about CDC.
Turn on your mic, sir.
Is the mic not on? Maybe I need to get closer.
Thank you.
I'll start over. Good afternoon, Chairwoman Underwood Chairs Underwood and Thompson, Ranking Member Rogers, and members of the committee. Thank you for the opportunity to talk with you about CDC's role in the response to the novel 2019 coronavirus, or COVID-19. Before I begin, it's important to recognize that this is a new virus and a new disease. The science continues to accumulate. We will continue to incorporate that new science into our response decisions and response posture. There are 3 overriding themes that have guided our response. First, CDC's role in this interagency response is built on decades of infectious disease experience and planning for pandemic flu and other health emergencies. Second, our response is dependent on support of a network of dedicated frontline public health workers in our communities, the state and local health departments. And third, as we begin to see community spread of this virus, it will be important for all of us to take action in preventing its spread through common sense public health precautions like hand washing, staying home if you're sick, and particularly for high-risk and vulnerable populations, avoiding crowds, especially in poorly ventilated spaces. I encourage you to visit CDC's coronavirus website to learn more about what you can do, and thank you for the second time we've been able to talk about the website and all the information that's there. From the outset, CDC and our U.S. government partners have implemented an aggressive, multi-layered strategy to slow the introduction of this virus into the United States, to buy time so that our scientists could learn how this virus behaves, to prepare our nation's public health system and healthcare system for the possibility of a global pandemic, which, as you've heard, has been declared today, and to educate Americans how best to prepare for disruptions to our daily lives and risk to our families. The administration's interagency containment strategy has relied upon tried and true public health interventions: early diagnosis, isolation, and contact tracing, travel advisories and targeted travel restrictions, selective use of quarantine for individuals returning from global transmission hot zones. Without immunity or treatment, our nation's public health response has relied upon detection and contact tracing to slow the emergence of this virus into the United States. February 25th was an inflection point for the outbreak when, for the first time, we saw new cases outside of China outpace new cases within China. We have observed rapid, widespread person-to-person transmission in South Korea, Iran, and Italy. And before long, we had detected our first case of community spread in California. So what have we learned? The virus spreads easily and rapidly, mostly through respiratory droplets from sneezing and coughing. going from 30 cases detected by Chinese scientists to over 100,000 cases worldwide in a little less than 2 months. Reports from China based on more than 70,000 cases of COVID-19 indicate that about 80% of patients had mild illness and recovered. 15 to 20% developed serious illness, predominantly in older persons and persons with chronic underlying medical conditions. For this reason, CDC has issued new guidance advising seniors to avoid crowds, stay closer to home, and avoid cruise ship travel and long plane trips. As of today, CDC has received confirmation of more than 900 cases of COVID-19 in 38 states, plus New York City and the District of Columbia. It is with great sadness that I report that there have been 31 deaths from this disease in the U.S. As we experience growing community spread in the U.S., state and local health agencies on the front lines will be making difficult decisions to reduce the spread with CDC guidance and support. Thank you for your support for additional resources to increase public health capacity in our communities. CDC has put more than 630 staff in the field and these are working side by side with other federal partners, state and local partners, and we've had over 1,500 people working on the response both in Atlanta and the field. CDC is committed to this mission, will continue to work 24/7 to protect the American people from this global health threat. Thank you, and I look forward to your questions.
I thank all the witnesses for their testimony. I will remind each member that he or she will have 5 minutes to question the panel, and I now recognize myself for 5 minutes. Americans want to know what they should expect in the coming weeks and months, and our state and local public health workforce and our healthcare system leaders need to know so they can do everything that they can to be prepared. Dr. Redd, I'm looking for numbers here. What are the current upper and lower estimates of total deaths due to the coronavirus that we should expect in the United States?
So I don't have an exact answer to that question. I think it is an important question. I think that there's a lot that depends on how aggressive our public health interventions are to really determine the ultimate course of this epidemic. There are many unknowns.
Yes, sir. What are the upper and lower estimates for hospital and ICU admissions?
I would give the same answer I gave to the previous question. The intensity of our public health intervention measures will determine the ultimate impact of this pandemic.
Okay, and then at current rates of detection and spread, when will California and Washington State run out of ICU beds and then also hospital beds?
Again, the better and more intensive our interventions are, the lower those numbers will ultimately be.
Okay. Do you expect CDC to do modeling that would be widely reported through like an MMWR or something like that?
A number of groups are doing that modeling. I'm not sure what our plans are. We're in communication with modelers from the UK and around the country on those sort of things. A lot of that has to do with estimating the value of interventions that might be undertaken and where they would have the greatest impact. I don't know whether or not those things from inside will be published, but there is a lot of information out there already.
Okay. For our health system to prepare to handle a surge in patients while protecting its workforce, providers need to be able to test every patient who meets the criteria based on symptoms and exposure. But we know that right now, as the governor of Illinois just said this morning, not everyone who should be tested has been. Dr. Redd, since December, how many Americans who meet the current criteria for being tested have actually been tested and received their results?
I can give you the number of people who have been tested, and let me find that in my cards here.
Okay.
The guidance has changed, as you know, recently.
I know. That's why we're asking about the current criteria, sir.
Right. I think we're around a little bit more than 1,700 people have been tested by CDC. There's a lot of testing happening in state health department labs now. Let me, if I might, take the opportunity to talk about, and tell me if you want.
Well, Dr. Redd, what we're really trying to understand is the number of tests that have been completed, how many tests need to be done to accurately depict community levels of spread in the United States. Do you have that figure?
what I'd like to do is walk through how the laboratory testing works in the United States.
Okay, Dr. Redd, we've heard that briefing several times here in the Congress. We have some very specific questions, sir. What's your plan to support states and communities to get those tests done? And when will that be done?
So we've taken aggressive action over the last several weeks. CDC has sent material sufficient to test 75,000 people through the public health system.
Right.
There are over 1 million tests available through the commercial system.
Yes, sir.
Both of those numbers are increasing as we speak.
Right. But my question, sir, was what's your plan to support the states to get those tests done for every single person who should be tested that meets the current criteria? There's a big gap between 1,700 and 75,000 and 1 million. Those are the three numbers you just outlined for us now.
That's true. I think that there are two different systems in play here. In the public health system, and this is not just for this disease, but in general, the role of the public health laboratories are to detect cases early of new diseases and then to be able to do representative testing to estimate the overall burden of disease.
Right.
There's a separate system, the clinical system, which is really for clinical care.
Yes, sir.
To make sure that a person gets treated for the right disease, that we don't assume that he has COVID-19 when there's a different treatable disease. And that is the much larger capacity that is actually being implemented rapidly compared with previous efforts with new diseases.
Okay, I'm going to stop you right there, sir. Is every test result from both the public and the private labs being fed into the flu surveillance system? Yes or no?
Right now, we're working to include the commercial laboratories in that system. The large commercial systems are being included. The public health laboratories are being included. There are others that are going to be kind of outliers that we'll work to include, but that would be the ultimate aim.
Okay, while there's still a lot that we don't know about the pathology of the coronavirus, we're seeing that seniors are among those experiencing higher mortality rates. So in addition to the coronavirus.gov that we both spoke about, CDC has a coronavirus information hotline, as I'm sure you're aware, for those who don't have internet access or who may not be as internet savvy, like some seniors. When the committee staff called the hotline, they consistently faced wait times of 30 to 60 minutes. How is CDC working to improve this hotline?
Let me get back to you on that. I think that's a very important thing that needs to be corrected, and so we'll take action on that.
Just more broadly, sir, our job is to steer the federal government towards the best possible outcome for public health. Modeling estimates help us evaluate outcomes. Surveillance informs modeling, and tests inform surveillance. We need to get all three right, sir, and we'll be making some really important decisions without a comprehensive view of what we're facing. So, Dr. Redd, we're going to be sending over some follow-up questions for you in writing, and we would appreciate your help in ensuring a prompt response. Thank you. I now recognize the ranking member of the full committee, the gentleman from Alabama, Mr. Rogers, for questions.
Thank you. Mr. Cuccinelli, this morning the CDC director said Europe is the new China in terms of outbreak. Is CBP doing more screenings of international travel from European countries to the United States?
So as each country, or in this case region, becomes more and more problematic, it obviously gets reviewed on a day-to-day basis. And I would tell you that it isn't just CBP. TSA is involved, CDC is involved. This is one of the things that the task force has considered literally on a daily basis as we've watched this pandemic move around the globe. As you know, I'm sure there is exit screening going on in Italy in particular, but Europe presents a unique problem. And because of the Schengen zone, where their borders effectively don't have borders for purposes of travel, there's 29 countries that we have to confront here. And the question arises, does treating, we'll take Italy, we'll continue with Italy, in the fashion we would China or even South Korea as a unitary entity even makes sense? So what the task force came to with respect to Italy is we are testing, in fact, the Italian government is doing it on the exiting side for direct flights to the United States. That's about half of those flights. very close to half. They have dropped from above 7,000 to just above 1,000 a day. So there's been a substantial drop in that travel. The reason that we chose not to expend the resources to capture the indirect flights is by way of scale, don't hold me to these exact numbers, to capture the last 2,000, 3,000, 4,000 travelers from Italy, depending on the day, and that was at full flight capacity, would require screening approximately 100,000 people. And those are resources that just, relative to the cost benefit, were more appropriate to apply to public health efforts other than that screening. So in Korea and Italy, we have allies who we trust and who are transparent doing exit screening. We're, of course, doing entrance screening for those from Iran and China or who've been through there. But the question is a live question, Congressman, about how to treat Europe as a whole. You've seen Department of State and CDC warnings go up. That is not to the level of using legal authorities to block travel yet, but it is under consideration.
Well, and it should be. That's the reason I brought it up. Right now, we're just dealing with a handful of those countries, as you know.
Right.
Given the freedom of travel throughout the EU, my view is we should be treating it as a region, as a unit, and expecting them accordingly. Let me ask, we just passed in a bipartisan fashion an $8.3 billion supplemental to help with this. I know a lot of that's going toward vaccine development,
right.
But it went from $2.5 billion to $8.3 billion real fast. Tell me how that money's broken out. What you going to do with it?
Well, as you probably know, the money that DHS receives comes through HHS. So I'll give you an example. FEMA has been with ASPR for about a month now, at their request as the lead federal agency in HHS, and our FEMA is reimbursed for those services effectively through interagency agreements. So the dollars you're describing from the supplemental that reach DHS come through HHS in exchange for services in accordance with the law.
Just FEMA, or won't CBP get some of that money?
Right now it is just FEMA. CBP, CWMD, the Coast Guard, TSA are all operating out of their base budgets for all the work they're doing, as is the S&T as well.
Do you expect that to be sufficient, given the new?
For the moment, we do, yes. If some things would have to change for that to not be sufficient, but so far none of those conditions have arisen.
Dr. Ridd, the Chinese government failed to give us notice for 2 months from the time of the outbreak till they did make the international community aware. What damage did that do to our ability to deal with this in a better fashion, if any, that you're aware of?
I think there's some things that they did well and others that they didn't. The reporting the outbreak quickly, posting the sequence of the new virus. There did appear to be a period of time when probably things were going on that weren't getting out of China. I think there were questions about whether there was human-to-human transmission. That initially appeared it might be just people exposed to animals. So I think that was a period of time when we were, there's not really anything we would have done differently. We were working on a diagnostic test. We were sending materials that started the ball rolling on vaccine production. As you know, within weeks of identifying the outbreak, really the restriction of travel from China reduced travel by 90%. I think that was a very helpful move to prevent more cases from China coming into the United States.
Thank you. Madam Vice Chair, I yield back.
The chair will now recognize members for questions that they may wish to ask the witnesses. In accordance with our committee rules, I'll recognize members who are present at the start of the hearing based on seniority in the committee, alternating between majority and minority. Those members coming in later will be recognized in the order of their arrival. The chair recognizes for 5 minutes the gentleman from Mississippi, Mr. Thompson.
Thank you very much, Madam Chair. In my earlier comments, I talked about the importance of transparency and communication. The public only gets what we tell them. And if we don't tell them accurately, then it's misinformation. Best example I can share in my opening statement The very first briefing we got, we were told that there's an 800 number. The briefers, as members of Congress, the briefers didn't know the 800 number. They had to go get the number and bring it to us. Now I hear that the number's working, but if as a member of the public who would call and be put on hold for 30 to 60 minutes, it's just absolutely too big a problem. So I hope that you look at it. Two of the people we heard from last week, one was a former head of CDC, and the other was a respected researcher from Johns Hopkins. They made very clear to us that communication and transparency in this kind of situation is absolutely important. So, Dr. Redd, can you tell me if the coronavirus task force is carrying out its meeting at a classified level, or are they open?
I know that the meetings are being held in a classified facility. I don't think that they're classified.
Well, I want you to check, because I think there are some challenges in that arena because they are, in fact, classified. And part of the problem a lot of us are having is an overclassification of information to the point that the public doesn't know. So look at that.
Actually, I'd like to agree with your major point, which is I agree that communication and information is a critical tool in combating the outbreak. People need to know what's happening. They need to know what kind of actions they can take to protect themselves. And it is really one of the most important tools that we have at this point.
So in line with the chairperson's question, how many test kits do we have as of today?
So on the public health side, 75,000. On the commercial side, over 1 million. It's somewhere between 1 and 2 million right now. The numbers are increasing rapidly.
So how would the test kits be dispersed?
So on the public side, they go to state health department laboratories and other laboratories that are part of our network for influenza surveillance. Actually, on the commercial side, it's however that system normally works. So it depends on the company. Some of them have facilities.
Well, you know, we're trying to help the public. And the public, you tell them we have 1 million test kits, but if somebody from CDC in your position can't explain to me how the public can access those kits, that's not very helpful.
I agree with that. I think that what people need to do if they feel that they are in need of a test is the first thing would be to call their doctor. The doctor would then, depending on how they have access to the test, it could either be through the commercial system or it could be through the public health system.
So are those 75,000 test kits that you talked about that are publicly available, does that address all of the current needs here in the United States?
It doesn't, and that's why the commercial manufacturers are such an important part of this.
Absolutely, but are they talking to each other? Get back to
yes. No, I think the answer is yes.
You know, we're trying to give the public some comfort that if you say we have 1 million kits, then there's a process that's defined for those 1 million kits to be accessed. And we don't have that based on what you're telling me. And I think one of the reasons we're here today is to put some clarity on how we address this situation.
Yes, sir. I think that the patient experience here is really critical, and that when they need a test, they can get one quickly and get the results quickly. That is the aim that we're hoping to achieve.
Thank you. And if the chair will indulge me just for Mr. Cuccinelli, on March 1st, 2020, a district court judge ruled that you were not lawfully appointed to serve as the acting director of USCIS, and that accordingly, the reduced time to consult and prohibitions on extensions directive must be set aside. Are you still serving as a senior official performing the duties of Director of USCIS in opposition to what the court ruled?
No, sir. The court ruled that in my position as principal deputy at USCIS, I was not properly occupying the position of acting director of USCIS. That is obviously something we're still analyzing and obeying the court order with respect to the 5 plaintiffs. My current position as senior official performing the duties of the Deputy Secretary derives not from my previous capacity as acting director of USCIS, but from my official position as principal deputy of USCIS. So as I perform the roles I'm here doing today as a senior official performing the duties of Deputy Secretary, that is not affected by the court's ruling. The court did not rule that I am inappropriately occupying my current position. It was the prior position.
So that's your interpretation of the court?
No, sir, that's the ruling.
Well, have you had the counsel for
Yes.
DHS look at that?
Yes, sir.
Did they provide you something in writing?
No, sir.
So what they just told you?
Well, it's pretty simple, straightforward, Mr. Chairman, so it wasn't hard for them to explain it to me.
Well, I would, as chair, we'd like to get it in writing, because I think the court was fairly clear that your present position was not consistent with the law, and in it, we are trying to massage it, just gets around it, but we'll look forward to getting that correction. I yield back.
The chair now recognizes the gentleman from New York, Mr. Katko, for 5 minutes.
Thank you, Madam Chair. Mr. Cuccinelli, is there anything else you want to add to the last line of inquiry before we proceed? No other questions?
I would just point out the timeline. It might help understand the ruling. The case was filed last summer when I was serving as the acting director of United States Citizenship and Immigration Services, as assuming that vacant slot from my position as principal deputy. The hierarchy, if you will, of the deputy secretary position as it currently stands traces back to the principal deputy for the United States Citizenship and Immigration Services. It does not trace back to either the director or acting director phrased in any way. That is why I gave the answer to the chairman that I did, and it was why I got the legal advice from counsel at DHS that I did.
Thank you, sir. Dr. Redd, I want to drill down a little farther in the previous line of inquiry as well. I'm trying to get a handle. So you have 75,000 tests in the government, in the government sector. You have 1 million tests in the private domain. What's going to happen to those 1 million tests? Where do they go?
So those, the purpose of those tests would be a clinician, a doctor, nurse practitioner, physician's assistant could order a test, and that would go just the way any test you would get in a doctor's office would go, would be sent to a commercial laboratory, either at the hospital or one of the large companies. You'd get a test result that would come back to your doctor. We're working on making sure that that information also is funneled into the government, so we'll be able to track those tests. But it's essentially a way of providing a test that could be used for clinical services, where public health testing generally is to detect the first cases and then to do surveillance. You don't have to test every case to do surveillance, but for clinical care, you do need a test for each person.
So I just want to make sure I understand this. Was it fair to say that you have the 1 million tests that are already available, plus you have 75,000 more tests, and all of them are getting in front line one way or another for testing of patients?
Yes, sir.
Okay. And how much more are going to be expected in the next few weeks that are going to be produced?
So the timeline I'm not so sure on, but it's going to be additional millions of tests in the commercial sector.
Okay, good. That's good to hear. Now, when we get these tests out there, it's fair to say that these numbers are going to go up. The number of positive tests are going to go up and go up significantly. Is that correct?
I think that's fair to say that we're going to identify additional cases with more testing.
Okay, and as these numbers go up, you're going to have to act accordingly on what's been considered by the World Health Organization now a pandemic. And I think we need to have the American people prepared for the fact that we are going to have a very serious rise in the number of cases. Has there been any estimates as to what they think it's going to be, the numbers next month or so?
So I think the total numbers really depend on the aggressiveness and intensity and effectiveness of our public health measures. One of the things that is happening just in our strategy to respond, early on, we wanted to identify every case, identify the contacts of that case, recommend self-monitoring to prevent further spread. At this point, the individual measures in some parts of the country where there is intense community transmission, those measures are not appropriate. There are more important things to do, and that is really when we shift to community measures, such as making sure nursing homes are especially protected, canceling large gatherings, recommending, as we have, that people that are at risk, seniors and people with chronic medical conditions, take different steps to protect themselves from becoming exposed. So it's a shift from a kind of an individual level case tracking to something that's broader and applies to entire communities.
As a matter of precaution, should we be doing any of those things now and not waiting until we get all these positive tests? Or what should we be doing now?
We should, and in fact we are in King County, Washington, in Santa Clara County, in New York City. In fact, today, I think maybe just as the hearing started, there was guidance posted based on a guidance document they released a few days ago, but tailored specifically for King County and Santa Clara, working with the health departments on what does it mean to actually apply this guidance to your community in the situation that you're in right now. I think that in general, these measures are more effective the earlier they are implemented, and we've seen that in other parts of the country, world, in Singapore, Hong Kong, where they've taken very aggressive measures, and in those cases had really good success in preventing the kind of transmission that we'd like to prevent.
And lastly, the line of the lab testing, could you just briefly explain to us, just so we're clear, how does the lab testing actually work?
So a specimen is obtained from a person. We're actually, the way that it's been done up now is a nasal specimen. So there's a device that's stuck in the person's nose to collect a specimen, a throat swab. That is put in transport medium. It's transported to a laboratory. There is a process of denaturing that specimen that might contain a virus. That denatured specimen is then put into a machine that assays for specific parts of the nucleic acid, the genetic material of the virus. There are also a set of positive controls, so to make sure the test would find it if it's there, and negative controls to make sure if it's not there, it wouldn't be detected. That then yields a yes or a no result. It also can tell you the concentration, something that's called cycle threshold. That's basically the number of times the machine has to go through this cycle. So a high number means there's not that much virus there. A low number means there's a lot.
All right, thank you very much. Yield back, Madam Chair.
The chair now recognizes the gentlelady from New York, Ms. Rice, for 5 minutes.
Thank you, Madam Chairwoman. Mr. Cuccinelli, during the past public health crises like Ebola and H1N1, the Department of Homeland Security played a pivotal role in a clear and coordinated federal government response. With the coronavirus, our state and local governments have stepped up to fill this role. States like New York have had to respond quickly to deploy emergency management and to work with local partners to keep our citizens safe. They, instead of your agency, are at the front lines of this outbreak. So for some reason it appears, and maybe you can enlighten me if I'm wrong, that DHS has not been on the front lines like they have in prior epidemics. And so could you clearly state what DHS's role has been in responding to the coronavirus and what you see as your role going forward?
Certainly. As we move further and further away from containment, which is where the Department of Homeland Security has a significant role, and into mitigation, which we've been doing for weeks now, as Dr. Redd has referenced implicitly a number of times, the frontline folks, and just pure volume of numbers, are your local and state public health authorities. We're following the pandemic plan put in place 2 years ago, which was the most recent iteration of that plan, and it in fact calls for extensive cooperation with the federal government supporting local and state efforts. The sheer number of medical and healthcare professional personnel required to address a pandemic like this puts us in the position of necessarily relying on state and local officials to be frontline fighters in this effort. And I'll give you an example. When we saw the Grand Princess problem developing off the coast of California, we had a unified command set up between the Coast Guard, CDC, California. But in practical terms, because those people were going to land in California, were most likely to be impacting California healthcare facilities and capacity, California very much had the lead and did a great job with it. And we're being very careful not to step on states or to tell them what to do. We are partnering with them as best we can. So,
okay, thank you. I'm just going to stop you there.
Sure.
It's now being reported that in my home state of New York, we have almost 200 cases of the coronavirus, which makes it one of 3 states with the highest number of cases. Before this hearing, I spoke with the head of the Department of Health in Nassau County, which is on Long Island, which my district is fully encompassed in. And I asked him, I said that I was going to be at a hearing with you, and I said, is there anything that you need that you don't have that the federal government can provide? And he said, what we really need, because now they're seeing more significant cases of community spread. For instance, in my district alone, the number of infected people has quadrupled since Sunday. Right. So I asked him, what can the federal government do? And he said, what we'd love is some guidance as to what public events should be canceled, what public events should not be canceled. Dr. Fauci testified today that large sporting events should be banned. So what is your guidance? They're looking to the federal government for some guidance on that issue so there can be a lack of, so we don't increase the panic and that states are not doing different things and getting people all riled up when they don't need to be.
Well, in the Department of Homeland Security, we essentially operationalize CDC guidance. We look to the CDC's guidance as well, and because of the novelty of this virus, it has been changing. And I know I'll turn it over to Dr. Redd, but...
Well, let me just stop right there. Okay, so I will follow up with that question. I just wanted to ask you, Dr. Fauci also said, quote, we would recommend that there not be large crowds. Would you consider a political rally in an arena that is filled to capacity with between 8,000 and 12,000 people? Would you consider that a large crowd?
We would consider probably anything over 1,000 people a large crowd.
Okay. Doctor, if you could, the question that Mr. Cuccinelli...
Yes, I think that the purpose of the gathering wouldn't determine whether it would be,
Well, let me tell you, do you agree with Dr. Fauci on that, that there should not be, that he said we would recommend that there not be large crowds? Would you recommend with him?
I would.
Would you, Mr. Cuccinelli?
Again, we look to the medical professionals.
I'm asking
for that
your
guidance.
opinion. You are in this.
I'm sorry,
at
I'm not going to
DHS.
give you my opinion. I'll tell you the opinions I look to operationalize.
So do you agree with? Do you agree with what Dr. Redd is saying?
Well, I certainly
Yes or
look
no?
to his employer for CDC.
Why can't
for
you
where
answer this question?
Well, I'm sorry, I don't know that
Is
it's
it because
a
the
can.
president has said that he has no plans to not have people, thousands of people, gather together in large crowds? Is that why? Because
So
Dr.
when
Redd
we
said
had
it in
this
2
decision to
seconds that
make-
he agreed with Dr. Fauci. Can you please give me a yes or no answer? Do you agree with Dr. Fauci when he said we would recommend that there not be large crowds?
I'm not prepared to do that.
Okay, that's quite unbelievable. I think my time is up. Thank you, Madam Chairwoman.
The chair now recognizes for 5 minutes the gentleman from North Carolina, Mr. Walker.
Yes. Do you need another minute to kind of go into detail, or are you satisfied with that answer?
Congressman, when we had this decision that we had to make last week, it wasn't 1,000 people, it was about 200 at our Seattle office. We took into account what the local authorities were doing. That was part of our decision-making process. We will adjust our decision-making based on what is going on in the particular community at issue. Would I have less reluctance in agreeing with Dr. Fauci if we were talking about Seattle? Yes. Than if we were in the middle of, an area of a state that was not experiencing interruption?
Absolutely. It's subjective. I know our Democratic governor just ruled that the NCAA tournament there in North Carolina should move on. So some of this could be geographically influenced. Would you agree?
Absolutely. And again, depending on what is going on in that local area.
What procedures do you have in place? Specific question here. I was recently in the Rio Grande Valley border. Over 60 different countries, or migrants from 60 different countries had been apprehended. This year alone, I believe several hundred Chinese nationalists have been apprehended as well. The procedures in place, if you arrest a migrant that is showing signs of respiratory problems, how do you handle that? Do you separate them or isolate them? What's the procedure in handling this?
So we have, prior to the existence of this virus, in place standard operating procedures because we do confront communicable disease on the southwest border with a certain degree of regularity. Those folks are transferred to ICE. They have quarantine procedures. If that is not available, CBP is in a position of having to rely on local healthcare systems to provide that support. Those are the two avenues we have.
Appreciate that. Dr. Red, thanks again for your long-term service. Appreciate what you're doing. There are reports that there are 2 strains of this virus. If the virus continues to mutate, does this possibly slow efforts to develop a vaccine or contain it in other aspects?
Well, viruses that are have the genetic material as ribonucleic acid, when they naturally mutate. It's in fact when we do sequencing, you actually get a bunch of different viruses, and there is a consensus sequence. So I think that they just naturally mutate. I don't think we can predict what will happen with the virus. It would be unusual for there to be enough mutation that a vaccine that we would produce against a strain now wouldn't work because of that kind of drift.
We had a very strong presentation yesterday in conference from Dr. Scott Gottlieb, who was pointing out the fact that he believes, in his opinion, that this will slow down in the summer or dissolve a good bit, but have maybe potentially a small spike back in the fall. Is that what you guys are seeing as well?
I think we hope that in the summer we will see a drop in transmission. I don't think we could say that we know that. That what you're describing is what happened with H1N1, where we had a fall or a spring wave. Things went low in the summer, still had more flu than usual in the summer, and then in August and September we saw a big increase. I think that does, if that were to happen, it would be a great thing because it would give us time to be more prepared for that fall wave.
Right, and traditionally the flu follows that pattern. Is that correct?
That's true.
Okay. We talked about it already. The World Health Organization has now listed this as a pandemic. Does that modify you guys' approach or change anything as far as the way you're moving forward with it?
It really doesn't. I think what that declaration was something that people working in this already knew, that it's around the world and there's lots of community transmission around the world.
Okay, thank you. We'll get time for another question with Mr. Cuccinelli. Do you have a plan for FEMA should an area that is the center of an outbreak, we were just talking about geographic and maybe demographics as well, if there is an outbreak that could be considered maybe the natural disaster, how does those two connect and what is your role in this?
So you're probably familiar with our IMAT teams that get deployed. For instance, Tennessee just had devastating tornadoes, and FEMA deployed its IMAT teams and then followed up with support. What we're designed around at FEMA is fairly large IMAT teams to respond to a natural disaster, as you described. But here we can and are seeing eruptions all around the country. So what FEMA has done is they've broken their IMAT teams down into smaller teams. So there's at least one for every single state and territory. They're smaller, 4 or 5 person teams. They've been trained specifically to support states and local officials under these circumstances, obviously different from a natural disaster. So we've adjusted our personnel. That's what we've been doing with some of this time is changing our setup, our structure, and our ability to reach out and more quickly support states and local officials in that capacity. If a local area is overwhelmed, if they have systems overwhelmed, at that point they might request FEMA assistance on a more traditional basis that you're used to. I would note the Stafford Act isn't really designed for this sort of situation, but there are analyses of that going on right now.
Thank you, Madam Chair. You're back.
The chair now recognizes for 5 minutes the gentlewoman from New Mexico, Ms. Torsmal.
Thank you, Madam Chair, and thank you for being here. I want to pick up on that string of coordination with state and local governments, because as you know, state and local governments are at the front lines of this crisis right now. And Mr. Redd, it's my understanding that it is the CDC's standard to notify state officials if individuals from their state were on board a suspected coronavirus-infected ship. Can you confirm that?
I think that depends on the setting, and I think that with the volume, we're working with the cruise industry to identify who would actually do that notification.
In what setting would you not notify a state if there was a
state? Yes, we would notify. Well,
oh, perfect.
Yes.
Okay, wonderful.
I think contacting the individuals is a different story.
Fantastic. Okay, and I appreciate that. If the state, you'll notify the state if they are. Today we learned that 2 individuals from my district who were on a cruise ship with suspected cases tested positive for the coronavirus. It's my understanding that the individuals returned to their local community for over a week before the CDC notified the state of New Mexico. What are you doing to rectify this failure of communication?
I'll have to look into that particular instance. I'm not familiar with that, and we can get back with you on what the specifics of that.
I appreciate that, and I know things are moving incredibly quickly, and so we're all working to just move forward better together. So to that note, will the CDC commit to sending a list of all individuals who have traveled to New Mexico from areas of concern today?
I think that list, I think this is one of the problems that we're coming into, is that there's transmission from so many different places that it sort of depends on what locations coming from would count as a place of concern. So I think this is one of the things that we're working with is many countries in Europe now have cases. It's not just northern Italy as it was a week or so ago. And I think this is one of the things that was referenced earlier, that there's daily discussion about what should be done about travel from locations just as you described. I think our current policy is problematic in that there's a lot of cases and outbreaks being sparked from travelers. You heard from the testimony this morning that Europe is the new China from the standpoint of coronavirus and exporting of cases.
Thank you, Dr. Redd. And just I recognize that this is a big problem you're trying to get your handle around, and so maybe we can identify some of the easier places to start in terms of state notification. Can you notify the state of all service members who are coming to New Mexico who've traveled from areas of concern?
I believe that notification is occurring.
Let's confirm that.
Particularly from, parts of the world that service members have been identified in. But we'll take that for action.
That's fantastic. And same with DoD personnel?
Yes.
Okay. And what about Public Health Service Corps members?
I think that is a reasonable suggestion. Let me though, I think this is one of the instances where the more places that have cases, we could essentially be identifying any traveler returning to the United States. And there's a point at which that ceases to be as useful as, particularly as it was earlier when it was China, or you could say China, Iran, South Korea, Italy.
That's fair.
So I think there's going to be a point where that notification, it's harder to take that for public health action because there'd be so many people everywhere. You could almost take a plane coming from Europe.
Thank you, Dr. Redd. Just switching quickly in my last minute. To date, how many people have been tested for the coronavirus across the United States?
So I can't give you an exact answer on that. There 1,784 have been tested at CDC. There are thousands that have been tested in the last week at State Health Department laboratories. And we are working on setting up the system to collect information from the commercial manufacturers. So that what you're describing, the question that you're asking is the one that we're seeking to be able to answer.
So 1,784 confirmed plus other places that you're working on seems lower than other countries where they are testing. South Korea, for example, can test up to 10,000 a day. Germany has done a lot. Do you have a timeline for scaling up testing in the United States?
Well, we have scaled up in the past week that there's 75,000 test kits for the, 75,000 materials sufficient to test 75,000 people on the public health side, $1 million on the commercial side. I would like to say that we cannot really test our way out of this epidemic, that's a part of the response, but there are many other important elements.
Absolutely, but it's a part we need to focus on. How many tests a day can we expect in the next few weeks?
Yeah, I think that's a hard question because there's all the other things besides having the materials are.
Do you have a goal?
Corporate. I think what we want is what everybody here wants, which is every person that needs a test can get it the same day. That would be the objective, and we're working towards that end.
Thank you. My time has expired.
The chair now recognizes for 5 minutes the gentleman from Pennsylvania, Mr. Joyce.
Thank you, Madam Chair, and thank you for holding this hearing. I would also like to thank both of our witnesses for appearing today and for keeping Congress informed as to what President Trump's administration and the efforts to combat and contain this novel coronavirus. Secretary Cuccinelli, thank you for mentioning in your testimony the work the DHS is doing to keep our frontline employees safe, especially given that the nature of their work leads actually to a higher risk of exposure. You mentioned in your testimony that all CBP personnel have access to personal protective equipment. Can you assure us that there is sufficient equipment for all personnel at CBP, and do you believe additional funding is necessary to ensure the ongoing availability of this protective equipment?
Congressman, tracking PPE for our employees has been something we've done from day one, well back into January. We are comfortably ahead of that curve. We keep a stock of 30-plus days on hand. We would probably say we have around 45 days available. That's standard for us, and we're not seeing a threat to that. We're not seeing a drawdown at a pace that is cutting into our ability to maintain protection and protective gear for our employed workforce.
Thank you, Mr. Secretary. On another matter, the lack of a full operational control of our southern border is something of particular concern to many of my constituents. Since taking office, President Trump has repeatedly asked for additional funding for the border security, including hard physical wall infrastructure. That has either gone unfunded or ignored by Congress. Briefly, Mr. Walker said this, but given the control that comes in and out of our nation is at the hands of CBP, it is imperative that we seek to prevent this novel virus from coming in through our borders. Do you agree that fully funding the President's budget request for border security is necessary for the protection of our country?
Well, certainly we do, Congressman, and the way you phrased it, border security, speaks to the comprehensive nature of the strategy we need to employ, which includes the whole wall system, but it also includes our people, the folks in the Border Patrol and in ICE who back them up, at USCIS who do much of the processing. That entire system is necessary to maintain security on our border. And one of the things, every month you all see the numbers of apprehensions and so forth, but what doesn't get talked about as much is what we call the getaways. There are plenty of people who are not caught. And when you think about that in terms of communicable disease, that takes on a whole new threat. It has existed with other communicable diseases, measles, to name one, TB, and we do see them across the United States at levels that many communities haven't seen in some time because of the situation at the border. We are not yet having a coronavirus problem at the southern border, but we are planning for such a problem as we see the case numbers in South and Central America rise precipitously as we are in other parts of the world.
Secretary Cuccinelli, you talk about individuals who are apprehended and those who get away. Have you apprehended individuals from China or other nations where we have known cases of the coronavirus?
We have not yet apprehended anyone crossing illegally or, I'll speak to legally in a second, who has tested positive for the coronavirus. We've apprehended almost 400 Chinese nationals since January 1st. no positive coronavirus tests amongst those individuals or any others at this point. We have also, based on the 212F proclamation the President implemented on January 29th, I should say 31st, effective February 2nd, we have turned away people from many countries of the world because they had been in China or Iran in the previous 14 days. And the number one category of foreign nationals we've turned away are Canadians. Chinese are second at our land ports of entry under the 212F authority. So we don't know who amongst those folks had what medical condition because they were turned away.
Thank you, Mr. Secretary, for your attention to this subject. And I yield my remaining time.
Mr. Cuccinelli, just wanted to follow up on that. Are you all testing every apprehended individual from an affected country?
I'm sorry, I'm sorry, ma'am.
Are you testing every individual apprehended from a coronavirus affected country?
No, we are not. No, we're not.
So you just said that there, out of the 400 Chinese nationals, that there was no coronavirus found. So how many of those 400 were you testing?
I don't know how many we've tested. We don't test unless we observe symptoms. Again, using already existing protocols. We're not creating yet new protocols to deal with potential coronavirus sufferers.
Right.
We deal with them as we would any other immigrant that we encountered. And of course, setting this virus entirely aside, one of CBP's roles, though not medically trained, is to observe those coming into the country for symptoms of illness in general.
Absolutely. Yeah, we're very well aware of the screening standards, passed a bill to that end out of this committee. Would you be willing to submit to us in writing a summary of those tests that CBP has performed on migrants apprehended at the southern border?
I would be happy to go determine how many immigrants we've tested for coronavirus.
And submit it to us in writing to this committee?
Yes.
Promptly, please. Thank you, sir. The chair will now recognize Mr. Rose from New York for 5 minutes.
Thank you, Madam Chairwoman. Mr. Rudd, would you agree that we will not be able to test nearly enough people without automated, automatic, or automated testing approved in our state laboratories?
I think that kind of testing is being done at the commercial scale. I'm not sure it's necessary in the public health scale side, and that's where these different roles that the two types of testing play.
So maybe I'm confused about something. My understanding is that automated testing needs to be approved by the CDC in conjunction with the FDA before it can occur in any laboratory, private or commercial or public.
There's a process of emergency use authorization, and that is an approval that the FDA grants to do a test that is earlier in development.
And you review it, though?
Well, we develop it. We basically...
So is it exponentially increases the number of tests that can be conducted in one day? It's significant. And we need for it to happen as quickly as possible. You would agree with that?
Right. I think that's right. I think whether we do that on the commercial side or in the public health side...
I don't care what laboratory is doing it. It's got to happen.
Exactly.
Has any laboratory in the country been approved for automated testing yet?
I can check on that. I can tell you that the LabCorp and Quest use those kind of systems, and they've been approved.
So is it happening anywhere in the country?
It's happening in those laboratories.
Okay, because it's not...
Let me verify that.
Now, there's a difference between semi-automated, there's manual, semi, and then full automated. We have to get to fully automated, correct?
Let's check.
Because I can tell you not one laboratory in New York has been approved. Can I have your word here publicly that you will make this a top priority to get not just in New York, but as many laboratories across the country approved for this as quickly as possible?
I think we want the same end, which is to have really every person that needs to be tested be able to get that test done the day that they need it. And to that end, I think the exact means that you use to get there, I don't want to quibble about that.
But you do agree we can't get there without automated testing?
Some level of automation, certainly.
Some level. Okay. So thank you for that. I look forward to working with you and your team to get New York there as quickly as possible.
It's a high priority, and I think what's going on there is something that we're working very closely with the health department on.
Do you have any sense of a timeline for how quickly we can get to these automated testings approved in New York?
Well, I think that this is not a problem that we can test our way out of. I think that that's part of the overall strategy. We need to be testing so that we understand where we need to be intervening, and we understand the effectiveness of those interventions. So I don't think for public health purposes, every single person doesn't need to be tested. For example, in the influenza pandemic 10 years ago, we weren't able to test everyone. We didn't need to test everyone. Our public health interventions were guided by the ability to extrapolate from the laboratory tests that we had.
Of course.
Different for clinical
Absolutely.
purposes.
Those who have symptoms, though, those who are symptomatic should be able to be tested same day. And we can't do that without these testings. It's necessary. It's not sufficient.
Right, but especially for clinical purposes. The public health, doing a representative sample doesn't help you if you're the patient. And
Absolutely. So my apologies in advance that we're going to be contacting your office every single day until this happens in New York and across the country. Mr. Cuccinelli, thank you for your service. I want to talk to you about foreign travel. Is my understanding that those foreign nationals traveling from China and Iran are now tested upon reaching a domestic airport. Is that correct?
No, that is not correct. They are barred from entering the United States.
Okay, so in terms of foreign screenings, though, which nations are we doing screening at?
So the way it works is the 212F only covers foreign nationals. The president doesn't have the authority under 212F to do anything to you and I as United States citizens. So U.S. citizens, legal permanent residents, and their families come in. Those are the people being screened at the airport. So an American citizen flies from China, and there are still some flights, to one of the 11 airports. They encounter a CBP OFO officer, the blue uniform folks you see when you come from another country. You show them your passport. Now they're going to see you came from China, and they're going to send you to secondary screening. That screening is run by CWMD, our contract medical personnel. And unlike the traveling questions that CBP asked you, they're going to ask you medical questions. These are medically trained personnel.
This is upon entry to the United States.
Correct. At the first
is there
point
any consideration of expanding that to other nations that are hard hit by this, Italy, for example?
Yes, there is regular consideration of that.
Okay. Do you think that's a good idea at this, knowing what we know right now, to expand that to South Korea, Italy?
Well, in the particular cases of South Korea and Italy, those allied nations took very quick affirmative steps to start performing exit screening. They are essentially doing on exit what our medical screeners would do on entry. And they did that in part to avoid being swept into a 212F situation. And that was acceptable to the president's task force, and he accepted it because of their transparency. These are allied nations who are being very upfront with us about what they're receiving. Sure. And they're also barring passengers who, for instance, test over 37.5 degrees centigrade for a temperature, just to use an easy one.
All I ask is that please keep us posted on your analyses going forward as to whether that should be expanded.
Glad to do so.
Thank you.
Okay, I'm going to wait for him to sit down. Okay. The chair now recognizes Mr. Bishop for 5 minutes.
Thank you, Madam Chairman, and I've had to step out for a bit, so you all may have covered some of these items, but Dr. Redd, do I still understand that it's the objective? The Vice President said that they were trying to make it so, the administration is trying to make it so that any doctor could order a test. Is that correct?
Yes, sir.
And I heard you recite the numbers that I was hearing last week, that there would be 1 million test kits sent out by the end of that week. Did that in fact occur?
It did, and that's from the commercial side, not the public health side. 75,000 was the number from the public health side.
Understood that. Do you get feedback to indicate that there are uncertainties on the part of doctors at this point in time whether or not they can order tests?
There are not uncertainties that I've heard.
Word is that schools and universities are closing. North Carolina has several. Is the CDC recommending pulling classes until the virus is more contained or slows?
So that is a local decision, and we've been working with communities that have substantial human-to-human community transmission. It's really a case-by-case basis, depending on the basically what the issue is, what set of activities need to be changed from the normal way. And we've actually posted guidance today for King County and Santa Clara County as examples of how to adapt our more general recommendations to particular communities. But we're working, I don't know the details of how we're working with the communities in North Carolina, but we would be working minute to minute with them on sort of titrating these recommendations to be the right intensity.
In response to the Vice Chairman's questions early on about how many persons you expect to be infected and so forth, you said it depends on the intensity of our public health response. How are you, I mean, are there questions about how intense to make it? I mean, you are part of the organization that decides how intense a response to have. So are you holding back, or have you decided what an ideal is, or is that changing day to day based on circumstances? And if it's changing based on circumstances, I would assume that would be test results indicating how widespread this is.
So I think that as communities identify cases in their community, there are a set of activities that there are questions. Should we cancel this event? Should we cancel that? Those aren't the kind of things we can have a federal guidance that would cover every eventuality. So I think this is an instance where it's a widespread event. The federal government can't cover every location. So our role is to support state and local health departments. There are going to be some instances where we can provide boots on the ground, but in general, we're going to be providing guidance and working with communities to make their decisions based on their own circumstances. And just for example, a large gathering, if it's people that are at high risk, so older people or people with chronic medical conditions, if that kind of thing is known, it would be a large gathering would be a smaller gathering than if it were teenagers.
Yes, sir. Thank you.
Congressman, could I add
yes, sir.
A little flavor to that as a former state attorney general?
Yes, sir.
For each of you, you all represent many different states, and your states have, in many cases, vast authority, legal authority in this arena. And it's easy for us in the federal government to overlook that, but your governors and your public health professionals have tremendous authority in this area, and many governors, of course, have declared public health emergencies and so forth. I've talked to a number of AGs, many governors. We've both talked to hundreds of local and state officials, and that is something that allows for the very specific surgical application of authority place to place, state to state.
Point well taken. Thank you, sir. And has your questioning today covered the fact that we have a no ban vote tomorrow on the Section 212F authority?
No, sir.
Well, let me ask you quickly then. We're voting tomorrow on this political no ban act to restrict the president's use of 212F authority. Didn't the president use 212F authority here in order to have an early intervention to stop Chinese folks, nationals, from coming in a way that's helped the response to this? That
is exactly what he used. It was available to use quickly at the advice of the task force, and it has been effective.
Would it have been a problem if that authority had been limited or restrained?
There is no question that the use of that authority has bought us time, and you've heard from both Dr. Redd and I various ways that we have used that time in the federal government, and our partners in local and state government have used that time to be better prepared as this virus advances.
Thank you, Mr. Cuccinelli. Thank you, Dr. Redd. I yield back.
The chair now recognizes Ms. Slotkin for 5 minutes.
Thanks, gentlemen. I just want to say at the outset that I'm really invested in your success. I think that we heard from the former head of the CDC who served, I think, under the George Bush administration, who talked about the importance of trust and how critical that is in a public health crisis or moment. And so I really want you to succeed. I want all of us to succeed. We're all on this boat together. And so I really want to have clarity for the people who are at home, who are looking to you all and to us for guidance. I guess I have the question on preparedness. And I think we've heard a couple of times from you, Admiral Redd, that the earlier we intervene, the fewer number of cases and the lesser the spread, for lack of a better term. I've seen other countries take much more aggressive steps. You know, Italy is now obviously has a lot more cases, but they're banned travel. People are staying in their homes. There's no going to tourist destinations. There's no public gatherings. Should there be anything else and guidance that we give beyond public health, washing your hands, giving a social distance? Should we be telling our businesses to go to telework if at all possible? Should we be getting people out of offices and schools? Not because this is such a terrible threat, and I don't want to incite, I'm just saying preparedness helps us blunt, unnecessary panic.
Preparedness does help. I would point to Singapore and Hong Kong as examples of aggressive early action that has blunted the epidemic.
So,
I think in the case of Italy, it may be a lot too late.
It got away from them. So what are the 2 or 3 other things that people should be doing besides the public health guidance to minimize the spread of this illness? Since Michigan, we just got our first 2 cases yesterday.
So I think that there are some individual actions and there are community actions. I think that all of these protecting the elderly and medically vulnerable is the highest priority because those are the people that are going to have the worst outcomes. So I think there is a lot of work around nursing homes in particular that needs to be undertaken to prevent the virus from getting into the nursing home. Things like reducing the number of visitors. If anybody is sick working there, being absolutely certain that that person isn't allowed back in. That people who work in one nursing home don't work in another nursing home. That when a patient is transferred from a nursing home to a hospital, they're not sent to another nursing home. Okay. These are kind of things that are known to spread other kinds of infections in that setting. And I think that the work that we do to protect people in nursing homes and the elderly is critical.
So can I ask a quick question? Because again, on the public trust issue, the issue of testing. So I will tell you that the sense in the public is that there's not enough tests. I'm glad to hear the numbers that you all offered, that there's 75,000 public health tests and another 1 million available commercially. We are not getting those to our states in a way that feels reassuring to people. And I guess I'm confused on why we're playing catch up on this. My understanding is we've tested 8,500 people across the country, but that South Korea is capable of testing 10,000 people a day. Can you help me understand why they're able to do that?
They have implemented a different system than the one that we're using. I think that we probably should be scoring ourselves on the ultimate impact of the epidemic and how well we control it. Testing is a part of that, but it's not the only part. So I am not sure. I mean, we don't have really good visibility on who's being tested. And if you're just testing people who are perfectly well, have not had any exposure, have a negative test, I'm not sure that really contributes to the public health outcome.
Okay.
I do think that I agree with what you're saying, that there is a sense that we haven't done enough in testing and we're doing everything we can to correct that. And I also agree with your statement about the importance of trust.
So I'm sorry, I just have one quick second. So a lot of us really do respect the head of the CDC, Mr. Fauci, Dr. Fauci. He's gotten us through a lot of crises. I guess I would ask that while you've devolved a lot of things to the states, and I understand things are going to be certainly a little bit different, I guess I'm just a prisoner to the fact that I was in New York City on 9/11, and whatever people think of Rudy Giuliani, he was clear, he was available, He was telling us what was good and what was not good. And I'm telling you that people are missing that. They're feeling like they want clearer guidance. And my strongest recommendation is that Dr. Fauci be allowed to take that role to reassure the country.
The chair now recognizes Mr. Crenshaw for 5 minutes.
Thank you, Madam Chairwoman. Thank you both for being here. I'll actually continue along that line of questioning because I have similar questions about what is the standard we're trying to achieve with testing. We do hear that South Koreans are testing huge amounts of people, and it makes people feel like they should also have a test whenever they want. Now, of course, you have to buttress that against the reality that we come up against, which is, are we then excluding people who actually need the test? And so I do want to get a more detailed sense from you of where we should be. What is the right realistic standard that we should be trying to achieve?